telling me. Okay, so this is just a pathway that I've talked about. This is a summary pathway. Extrinsic and intrinsic, okay? Now let's talk about necrosis. Look at this one here. What can you, no. This is apoptosis, I'm sorry. So look at the arrows. They're pointing at apoptotic bodies. So here you have epithelial cells, you have a condensed nuclei. These are your apoptotic bodies, okay? We talked about abnormal regulation of apoptosis. You have follicular lymphoma. This is in the future, okay? But for now, remember them. Translocation 1418, follicular lymphoma of Burkitt's. 814, this is CMYC. This is EBV, Epstein-Barr virus. Cervical cancer, don't forget, HPV, right? E6 binds to P53. E7 binds to retinoblastoma. This is a nice table. Put a star here. The difference between apoptosis and necrosis. So what is necrosis? If I have exogenous injury, what happens to the plasma membrane? It damages and it undergoes enzymatic degradation. The components leak out of the cell and I have local inflammatory reaction. That's the main thing that separates necrosis to apoptosis. Only in necrosis you have an inflammatory response. Look at this image now in your in the kidney. Look at the arrows there, the green arrows. What can you see there? What kind of necrosis do you think it is? It's a solid organ, kidney, so
coagulative necrosis.
Excellent. So you can have coagulative necrosis. Commonly seen in what? In infarction, right? Most tissues, except for the brain, okay? The brain is always liquefactive, right? Coagulative necrosis happens due to what? Ischemia or infarction, right? You look at the histology. So they're going to give you histological slide. So what can we see in histology? You can see preserved cellular architecture, right? You can see this an outline. Cell outlines can be seen, but you don't see the nuclei. The nuclei disappear. You can also see eosinophilia. So it's much more reddish, red-pink in color. So that's your coagulative necrosis. Let's look at this one. What lobe are we looking at? Look at this. There's something going on, a necrosis. On what lobe? What do you think? So remember your basic brain anatomy, right? Don't forget that. So we have your lateral ventricles here, right? You have your globus, internus, externus. Then you have the different lobes, right? So here we can see hemorrhagic stroke. What artery do you think is involved here?
Middle.
MCA. This is middle cerebral artery. So MCA supplies your what? Temporal. And also frontal, right? Remember your superior lenticulostriate arteries, right? It supplies your Broca's area, and then your inferior lenticulostriate, it supplies your Wernicke's area, okay? Integrate materials, please. It will gonna help you next term, trust me. So liquefactive necrosis, seen in what? Brain infarction, that's high yield. Also bacterial abscess. It is due to what? Neutrophils. So they release their enzymes. And these enzymes, they digest the tissue. So what can we see in histology? If they give you a histological slide, you can have cellular debris and macrophages. You can also see cavitation. Look at this one. A big cavity in the brain. You can have cystic spaces. So that's liquefactive necrosis. Let's look at this image here. It's a nice image. What do you think this is? What kind of necrosis is this? In the lungs, right? What are we thinking? This is a pulmonary cavitation, so caseous. This is caseous necrosis. This is TB, right? Seen in TB. You're gonna learn later. Systemic fungal infection. Example: histoplasma, your blastomyces, your coccidioides, right? Your nocardia infection. This is due to what? The macrophages, they are trying to wall off the infecting organism. So your CD4 cells, right? Th1 cell, they're trying to fight your Mycobacterium tuberculosis. They're trying to wall off the infection. That's why you can have a granular debris. So what can we see in histology? This is a good histological slide. What can we see? You can see fragmented cells and debris surrounded by your lymphocytes and macrophages. You have a granuloma formation here, granulomatous formation. Okay, that's caseous necrosis. Now look at this one here. This is caseous necrosis, right? Specifically a granuloma formation. In TB, think granulomatous formation. Contrast that with this one here. Look at the blue images. So this is sarcoidosis. This is non-granulomatous formation. How can I differentiate granuloma formation with non-granulomatous formation? In non-granulomatous formation, you can still see the nuclei. Can you see that? You can see nucleus, right? The nuclei is still there. Here, there's no nuclei in the center. Okay, that's high yield. Why? Because in granuloma, you have necrosis. You have central necrosis in granuloma formation. In non-granulomatous formation, right, you have necrosis. Okay, good for now. Let's talk about this one. Ooh, look at those feet. So this is what we call gangrenous, commonly seen in what? Digital extremities and your GI tract after chronic ischemia. There are two kinds, dry and wet. Dry is only due to ischemia. If there is an infection superimposed to that dry gangrene, it becomes wet. Wet gangrene. Okay? This is a nice picture of dry gangrene. Look at the black thing here on the patient's right foot. You have dry gangrene. High yield here, the table, the star. You need to know the types of necrosis, definition, the pathophysiology specifically. They're going to give you a histological slide. You need to know the appearance of the slide and some examples. Let's summarize then. Types of necrosis. Necrosis, think local inflammatory reaction. Different types. Coagulative, seen in ischemia. If there is ischemia in most tissues, think coagulative. Histology, you can have a preserved cellular architecture. You can still see the cell outlines, right? And you can have increased eosinophilia. The eosin stain has increase in cytoplasmic binding. You have an increase in pink color of the cell. Liquefactive, seen in brain infarction. It is due to neutrophil releasing their lysosomal enzymes that digest the tissues. You can see cystic spaces and cavitation, specifically in the brain. Caseous necrosis, seen in tuberculosis, and later systemic fungi. This is due to macrophages walling off the infecting microorganism, your CD4 cells, right? Th1 cells. They're trying to wall off the infecting organism. What can we see in histology? Fragmented cells and debris surrounded by lymphocytes and macrophages. You can also have granuloma formation. There is no central necrosis involved in granuloma. Fat necrosis. I forgot to tell you this one. Fat necrosis, think pancreatitis, acute pancreatitis, or traumatic injury to the breast tissue, right? So you damage the pancreas, you release lipase, which breaks down your triglycerides. And these fatty acids, they bind to calcium. And we call that process saponification, which has a chalky white appearance. Okay? So what can we see? It appears dark blue on your H&E stain. Fibrinoid necrosis, this is due to what? Immune or non-immune? Immune, well, example, polyarteritis nodosa, right? What kind of hypersensitivity reaction is this? Type 1, 2, 3, or 4? 3. Excellent. 3. 3 letters. PAN. So it's immune complex deposition, type 3. Also seen in hypertensive emergency and preeclampsia. Don't forget. So you have immune complex deposition and you have protein leakage from your damaged vessels. What can we see in the vessel? In histology, the vessel walls are thick and they're thick. Gangrenous, where can we see gangrenous? Commonly seen in digital extremity and GI tract after chronic ischemia. It can be dry or wet. Dry is ischemia only. Wet gangrene, if there is an infection, a superimposed infection, you can have wet gangrene. Excellent. Now look at this one here. So let's look at the cell. What do you think is happening here? So you can have, this is the liver cell, a hepatocyte, right? What can we see? Look at the intermediate filaments. They look clumpy, right? So you have clumping of your intermediate filaments. Can you give me examples of intermediate filaments that you already know? So your desmin, your cytokeratin, your vimentin. Why is it important, this intermediate filaments? Come on, guys, work with me here.
Helps for staining, or?
Exactly. So your immunohistochemical, right? Staining. For example, desmin for muscle, vimentin for mesenchyme, epithelium, you have keratin, or cytokeratin. Those are high yield. We're going to talk about that later when we talk about neoplasia. So here, we're talking about intermediate filament clumping. This is actually a Mallory body, right? So this is steatohepatitis. What do I mean by steatohepatitis? You have an increased storage of your triglycerides and cholesterol and complex lipids in the cell. If you eat at McDonald's every day, guys, or Wendy's, you can have steatosis of your liver. Can you imagine that? Fat deposition in your liver, in your heart, in your muscles, in your kidneys. What's the stain? High yield Sudan stain or oil red O staining. Okay. Example, if you're alcoholic, of course, you can have presence of your Mallory bodies or Rice syndrome. What is this Rice syndrome? Rice syndrome is due to, that's why you don't give aspirin to kids, right? Because it can induce Rice syndrome. Don't ever give aspirin to kids. Aspirin, reversible or irreversible inhibitor of COX?
Irreversible.
Irreversible inhibitor. Increase in Km, same Km. Same Km. What happens to Vmax? Decrease in Vmax. Excellent. That's from term 1. Don't forget. Integrate materials. So let's talk about calcification. This is high yield table. 2 types of calcification, metastatic and dystrophic. So metastatic calcification, it involves normal tissues, right? It's diffuse calcification of your normal tissues. What happens to serum calcium? It's increased, right? What can we see in the histology? You have some speckled calcium throughout your soft tissues. This is secondary to hyperphosphatemia due to chronic renal failure. In dystrophic, these are localized calcification of inflammatory sites or necrotic tissues. When there is necrosis, think about dystrophic calcification. This is secondary to local injury or necrosis. Some conditions there, just read that one. What happens to the serum calcium? It is normal, okay? In histology, you can see basophilic granules and samoma bodies. So this is high yield. Let's compare and contrast again. Dystrophic calcification, localized calcification, can be seen in local injury or necrosis. What happens to calcium? Normal calcium. What can we see in histology? Samoma bodies and some basophilic granules. How about metastatic calcification? This is diffuse calcification of what? Normal tissues, secondary to hypercalcemia. You can have primary hyperparathyroidism. So if I increase PTH, what happens to the calcium level? If I increase PTH, what happens to the serum calcium? It also increases, right? It also increases. So you can also have hypervitaminosis D, sarcoidosis. PTH acts on the kidney via what enzyme? How does it increase calcium in the kidney? 1-alpha hydroxylase, okay? Integrate materials, okay? So you have increased bone resorption. We're gonna learn later about Paget disease or some multiple myeloma. What happens to the serum calcium? Increased, okay? Don't forget, metastatic calcification, increased serum calcium. What can we see in histology? Some finely speckled calcium throughout your soft tissues, okay? Good. We're good so far? Yeah?
Yeah.
Okay, so hyalinization. So if I have leakage, right? So if I have, for example, damage to my alveolar epithelium, I can have leakage of proteins there. So it forms hyalin. So there's a process called hyalinization, which is a replacement of your normal tissue by proteins. They are eosinophilic. So when you look in the slide, they look pink, right? Red, pink in color. There are different kinds of intracellular hyaline. Mallory bodies. Mallory bodies, think about alcoholic liver disease, right? You can also have Councilman bodies. These are for viral hepatitis or yellow fever. Yellow fever, zone 2, viral hepatitis, zone 1 of your hepatocytes. You can also have Showman bodies, granulomas and sarcoidosis, or Russell bodies. For now, I think just know the term for each, because when you go over the diseases in the next module, you're gonna learn more, okay? So hyalinization, meaning I replace the normal tissue by proteins, right? They are eosinophilic, okay? And know the different kinds of your intracellular hyaline. Your extracellular hyaline is due to what? It can be due to vascular changes, for example, hypertension. You have hyaline arteriosclerosis, fibrin also, and some amyloid. Amyloid deposition, for example, in Alzheimer's, you have your A-beta amyloid. Now, let's talk about inflammation, acute local inflammation. So this is an immediate response to what? To a pathogenic factor. Is it rapid? It is rapid onset. Is it short-lasting? It is short-lasting. Is it transient? It is transient. What kind of immune system does it involve? Is it the innate or the adaptive? Only the innate immune system. It is characterized by what? Your 5 classic signs of inflammation. Now, guys, from term 1, can you give me the classic signs of inflammation?
Rubor.
Okay, go ahead.
Pallor.
Pallor, good. What else?
Tumor.
Okay, pain, good. Okay, there
Loss
are
of
five,
function.
right? I just because when you teach it to us, I always remember the Latin names because I'm fancy, right? So you have, oops. So you have rubor, calor, tumor, dolor, functio, liaisa. Now, for each of these classical signs of information, you need to know the mechanism and you need to know the mediators. Okay, I think it's here. Okay, let's do that one. So redness. Why do I have redness? This is due to what? Why do I have redness and calor? Rubor and calor, redness and heat. This is due to vasodilation. You're increasing the blood flow. What's the most important mediator for your redness and heat? It's histamine, prostaglandins, and bradykinin. That's high yield. Okay. Don't forget, histamine is preformed. Your prostaglandins are synthesized via the arachidonic acid pathway. And bradykinin, don't forget, if you give ACE inhibitors, it can cause angioedema. Why? Because you're increasing the bradykinin levels. It is activated by what factor in the cascade, the coagulation cascade, your bradykinin? Factor 12, okay? Don't forget that one. How about tumor? Why do I have swelling, right? So first you have increase in vascular permeability. You have tissue damage, of course. If I have tissue damage, I have increase in vascular permeability. What happens to the fluid? It leaks out, right? It leaks out into the interstitial space. So where does it leak from? High yield post-capillary venules. It leaks out from the post-capillary venules into where? The interstitial space. This is what they call an exudate. Did you talk about the difference between the exudate and a transudate, or not yet?
Yes.
Yes, we did.
So tell me the difference. Exudate versus transudate.
Exudate contains like proteins and
So it looks milky, right? How about a transudate? It looks watery. It's like water, low protein, right? And I think next module, we're gonna learn about how to calculate if it's a transudate or an exudate. So what are the mediators for your swelling? Again, don't forget histamine, right? Leukotrienes, your C4, D4, E4, and your serotonin. So for calculating whether it's transudate or an exudate, you need to know, I think next term or next module, Light's criteria for that one. So you just measure the protein in the serum, the LDH, right? And all of those good things. Why do you have pain, dolor? We have sensitization of your free nerve endings. What's the mediator? Don't forget bradykinin for pain and fever, right? PGE2 for pain and fever, and histamine, okay? And why do I have loss of function? This is the combined effects of everything. Let's summarize. Know the sign, mechanism, and mediators of each. Redness and warmth. Why? Vasodilation, which increases blood flow. Important mediators, histamine, prostaglandin, bradykinin. Swelling, you have from tissue damage. If I damage a tissue, I increase the vascular permeability. There's leakage of protein-rich fluid from the PCV post-capillary venules into interstitial space, thereby forming an exudate. Therefore, if there's protein in the interstitial space, what happens to the oncotic pressure? I increase the interstitial oncotic pressure. Important mediators, leukotrienes, C4, D4, E4, histamine, and serotonin. How about pain? Pain, why? Sensitization of sensory nerve endings. Important mediators, bradykinin, PGE2 for pain and fever, PGE2, and histamine. Lastly, loss of function, you have everything caused by the combined effect of all the other cardinal signs. Okay, so here's another good slide with the mediators and some of the sources. So first, what happens in acute inflammation? You have an increase in vascular permeability. So what happens? First, you have transient contraction of your endothelial cells, right? However, this transient contraction, it does not last long because you're trying to minimize blood loss. However, it's only transient, right? And then what happens next? You have endothelial injury. You have leakage until the damaged area is thrombosed or repaired. So what happens here? Increase in vascular permeability. You have leakage of plasma content into the interstitial tissue, causing edema. But also, this allows your immune cells to go to the site of injury or your infection. In acute inflammation, you also have some chemotaxis and leukocyte extravasation. So the leukocytes, they interact with your epithelium. They leave the blood vessels to migrate to the site of infection. It occurs in 5 steps: margination, rolling, adhesion, diapedesis, and migration. High yield, let's talk about each one of them. Where does leukocyte extravasation occurs? Where do you think it occurs?
The post capillary venule.
Excellent. That's high yield. PCV, it occurs in the post capillary venule. So let's talk about margination. So margination, what is in the leukocyte? Your sialyl Lewis X. It's always in the leukocytes. And remember, your selectin and p-selectin are always in the endothelial cell, right? Your p-selectin, they comes from where? It comes from where?
To Weibel bodies.
Weibel Pallady bodies. Give me something that's important in the coagulation cascade. That's also in your Weibel Pallady bodies. It's also stored there.
Von Willebrand factor.
Excellent. Von Willebrand factor. Von Willebrand factor binds what?
No.
So if I have an exposed collagen, right? So von Willebrand factor is there. It is expressed, right? If I expose collagen, increase expression of my von Willebrand factor, the first platelet will gonna bind the von Willebrand factor via what receptor? GP?
3B or 3A.
GP1B, right? 2B, 3A is between platelets. So we have, don't forget, Glanzman, right? Oh, no, Bernard Soulier. Bernard Soulier is GP1B. GP2B3A is your Glanzman. Thrombo. Yeah. Okay, so that's margination and rolling. If I have a defect in my sialyl Lewis X, if I have a defect in my leukocyte, what is that disease? Leukocyte adhesion deficiency, your LAD. Okay, don't forget that. LAD, leukocyte adhesion deficiency. In the vignette, they're gonna say delayed separation of the umbilical cord. So when you have that one, think LAD. Okay, next I have adhesion or tight binding now. So it rolls. Think about the selectin as a speed bumps, right? Now I have adhesion. What's in the leukocyte? My integrins, CD11, CD18. I also have VLA there. It's low yield. In the endothelial cell, I have my CAM, CAM, right? So I have ICAM, I have CD54, CD106, right? Your ICAM and your VCAM, they are in the endothelial cell. Next, what happens? Diapedesis or transmigration, meaning the leukocyte, it travels between the cells and exits the blood vessel. So you have PCAM, PECAM, okay? Your CD 31, PCAM1, okay? And then migration. The WBC travels through interstitium to the site of injury or infection. Throw back to term 3. Give me the chemotactic factors for this, for migration. For neutrophil chemotaxis. What are the chemotactic factors?
C5A,
C5A, what else?
LTB4,
What else?
C3A,
E3A, good. What else?
and bacterial factors.
So C5A, IL-8, LTB4, kallikrein, and platelet activating factor. What's high yield here? Know the 5 steps. Know what it means. Know the receptors involved. What is in the leukocyte? What is expressed in the vasculature? Step 1, margination enrolling. Leukocyte, you have the sialyl-Lewis X. In the vasculature, the stroma, you have the selectins. Selectin, speed bumps. Think about speed bumps. They slow down your leukocytes. Next, you have tight binding. In the leukocyte, you have your integrin, CD11 and DC8. You also have VLA4 there, your integrins. In the vasculature, you have ICAM, CD54, right, 54, and your VCAM. In diapedesis, you have both of them. In your leukocyte and vasculature, you have PECAM, your CD31, 31. And in migration, don't forget the chemotactic factors, C5A, IL-8, LTB4, kallikrein, and your platelet activating factor. So here it is again, a good summary slide. Highlight that one. So yield, diapedesis, highlight it, PCAM, leukocyte migration, chemoattractants, high yield. Put a star on this slide. Put a star on this slide also. So it separates the important receptors between your leukocytes and your endothelial cell. This is a high yield slide. Again, another one, if you like tables, like me, put a star here. It separates between endothelial cells and leukocytes and some notes, okay? All right, phagocytosis and killing. In the end, you have phagocytosis. You have recognition of a target, engulfment, and degradation of engulfed particle. What's high yield here? Killing and degradation, oxygen dependent and oxygen independent. Which is better? Oxygen dependent, right? Don't forget your respiratory burst. There's a immunotie-in, your CGD, deficiency of your NADPH oxidase. So if I have acute inflammation, right? What's the outcome? Either 1, resolution with regeneration. That's good. I like that one. Know the mediators and cytokines involved. IL-10, TGF, beta. Or I can have resolution, but I have scars. It's still okay, but I have some scars. That's all right. What's the factors involved? PDGF, TGF, beta, right? Remember, resolution, think about TGF, beta. You're having fibrosis, think about TGF beta. Or worst, I have abscess formation. Think about tumor necrosis factor, TNF. Or it can progress to chronic inflammation. God. So I have infiltration of affected tissues, right? So I have this cytokines, your IL-1, your TNF, your IL-12, and your IL-6. Let's summarize. Acute inflammation, transient, earlier response to injury. In tissue, I can see neutrophils. Neutrophils with what? Edema. It has a rapid onset and short duration. Why? Because it's only the innate immune system that's involved. Okay? So mediators, don't forget, toll-like receptors. You have your neutrophils, eosinophils, mast cells, basophils. All right? You can have vasodilation, you have increased endothelial permeability. You can have extravasation of leukocytes from your post-capillary venules, right? Don't forget the steps in your leukocyte extravasation, margination and rolling, adhesion, transmigration, and migration. Don't forget the outcomes and the associated cytokines. That's high yield. I can have scarring. I can have chronic inflammation. So the activation of my, what is that? CD4, TH plus cells. I can have abscess. Ooh. I can have persistent acute inflammation, IL-8. Or the best way is resolution and healing. Don't forget IL-10 and TGF-beta for that one. Now, if worst comes to worst, I didn't get resolution and healing, it progresses to chronic local inflammation. So there are two mechanisms. So now we are involving your CD4 positive TH cells. So you have monocyte macrophages and your lymphocytes. This one sucks. It may last for months, 2 years. You have two pathways, classical and alternative. Classical, TH1, you're fighting the infection, interferon gamma. Alternative, TH2, your body gives up anymore. You're just walling off the infection. You can have TH2 cells secreting IL-4 and IL-13. What are the outcomes of your chronic inflammation? Scarring, okay, amyloidosis, or neoplasia, which is the worst one of them all. Now let's talk about this one, granulomatous inflammation, right? Difference between granulomatous and non-granulomatous inflammation. So this is due to infections, TB, systemic fungal infections, or vasculitis, or some foreign body exposure. So this is characterized by a formation of a granuloma, right? Granuloma. You have areas of central necrosis in the granulomatous inflammation. What is the pathophysiology of your granulomatous inflammation? This is a chronic inflammation. It is induced by a T cell response. Remember, T cell response is also involved in type 4 hypersensitivity reaction. What's the purpose of the granuloma? What do you think is the purpose of the granuloma?
Isn't it to wall off the infection?
Exactly. So your body cannot completely or degrade, right, the organism. Therefore, it just walls it off, right? It can't just degrade it. Okay, so you have persistent inflammation, you have fibrosis, and organ damage. In terms of histology, what can we see in caseating? Caseating, high yield, don't forget, central necrosis. In your TB, you have central necrosis. C, caseating, C, central necrosis. Commonly seen in TB and fungal, systemic fungal infections. Non-caseating, no central necrosis. N, non-caseating, it begins with N, so it's no central necrosis. Commonly seen in what? Autoimmune diseases, your sarcoidosis, your Crohn's disease. Now, could someone tell me the mechanism of your granulomatous inflammation? So we have an antigen-presenting cell. It has an antigen. It encounters your TH1 cell. It presents it via, so the APC present antigens to your CD4 positive TH cells, and it secretes what? IL-12. Don't forget IL-12. This one, and IL-2. The CD4 positive TH cells will then differentiate into TH1 cell. The TH1 cell, it secretes your favorite, interferon gamma, which activates macrophages. The macrophages then secrete your favorite again, TNF, tumor necrosis factor, which causes the formation of your epithelial macrophages and giant cells. So if I give you an anti-TNF alpha drug, right? What happens to the granuloma? If I give you an anti-TNF drug, what do you think happens to the granuloma? Anyone? So the granuloma starts to break down. If it's, remember, your macrophages, they're the ones that maintaining that granuloma. You're the ones that secreting TNF. So if you give anti-TNF drugs, you are breaking down the granuloma, thereby you are disseminating the disease. So what's important? There's a pharmacology tie-in there. What do you need to do? If you give anti-TNF alpha drug to a person, what do you need to do?
PPD.
PPD. Why?
To see if they have a tuberculosis infection or
Exactly, because you don't want that to disseminate, right? Remember, miliary tuberculosis, it can go everywhere. It can go to the brain, it can go to your kidneys, it can go everywhere, to your spinal column, it can go everywhere. Also, remember, your macrophages, it can increase hypercalcemia, okay? Due to increase in alpha hydroxylase activity, right? If you have an increase in vitamin D activity, you can also have hypercalcemia due to increase in 1-alpha hydroxylase activity. So what's the high yield point here? Know the pathophysis of granulomatous formation. What can we see in histology, right? 2 types of granuloma, caseating granuloma, think C, central necrosis. Non-caseating granuloma, think no central necrosis. Learn the diseases associated with each: caseating TB, fungal infection; non-caseating sarcoidosis, Crohn's disease. The pathology will be discussed in your next module. Now, look at this image. Is it caseating or non-caseating? Non-caseating. Why? There is no central necrosis. How do I know that there is no central necrosis? I can still see the nucleus of the cell. Okay? I can still see that. Look at the blue image. The highlighted, no, it's not blue, it's green, right? It looks like light green. It's highlighted there. This is a non-caseating granuloma in sarcoidosis. How about here? Look at the arrow. It's pointing at, look at the arrow. It's pointing at a group of cells. This is a caseating granuloma. Why? There is central necrosis. How do I know that there's central necrosis? There are no nuclei. You cannot see the nucleus anymore. Is that good? That's high yield. If they just give you a slide and they say, what's this? Granulomatous or non-granulomatous? Right? Think if there's necrosis, right? Always in caseating, you have central necrosis. How do I know that there is necrosis? I can't see the nucleus anymore. Okay? That's high yield. We're moving on. We're good so far? Yep. Yes, no?
Yes.
Okay, let's go. Principle of neoplasia. What do I mean by neoplasia? So we have normal cells. So this is uncontrolled monoclonal proliferation of cells. It can be benign, malignant. So tell me, normal cells, the characteristic of a normal cell. Can someone tell me?
A 1-to-1 ratio for cytoplasm and nucleus. Or...
Excellent. Good, good, good. What else? Look at the image here. They're nicely stacked. They have what? Apical polarity, right? Good. They're normal cells with the basement membrane intact, right? You still have the blood vessels there and lymphatic vessels, right? So normal spectrum. Now let's look at dysplasia. Look at the image here. Dysplasia. What's happening? You have pleomorphism. You have loss of uniformity in cell size and shape. Look at the tissue orientation. They are not stacked nicely, right? So we have loss of tissue orientation. Look at the nuclear changes. What's happening? Some of the cells have increased nuclear cytoplasmic ratio. Now, if this progresses, it becomes carcinoma in situ. In situ means on the site, okay? Carcinoma in situ. This is pre-invasive, okay? So what happens here? You have irreversible severe dysplasia. Does it involve the entire thickness of the epithelium? Yes or no? Does it involve the entire, look at the image. Does it involve the entire thickness of the epithelium?
Yes.
Does it invade the basement membrane?
No.
Yes.
Careful. Does it penetrate?
No, no.
Okay, good. It does not penetrate the intact basement membrane. Now, if this stressor progresses, right? Blah, blah, carcinoma in situ, it becomes invasive carcinoma. Now, high yield. You have now invasion of the basement membrane. The basement membrane is not intact. What does the cell uses to invade the basement membrane?
Hyalinization?
Okay, hydrolase, right? High yield metalloproteinases, right? Metalloproteinases. What cofactor? Term 2, what cofactor for your metalloproteinases?
Zinc.
Excellent, zinc. What else? Aside from your hydrolases or your metalloproteinases?
Collagenases.
Collagenase, by the name itself. What's the function of a collagenase?
Break down collagen.
Exactly. And look at the cells. They lost. So the cell-to-cell contact, right? They lost something. They inactivate E-cadherin. Okay, so your desmosomes are gone, right? And then look at the last one, metastasis. Now you have, it now spreads to your distant organs via lymphatics or the blood. Let's summarize. Normal cells, apical polarity. If the irritant progresses, or if it persists, it becomes dysplastic, dysplasia. You have pleomorphism. Think about increased nuclear cytoplasmic ratio. If the irritant is still there, it progresses to carcinoma in situ, which is pre-invasive. It involves the entire thickness of the epithelium. However, it does not penetrate the basement membrane. It can progress to invasive carcinoma. It invades the basement membrane using your metalloproteinases and your collagenase. You also have inactivation of your E-cadherin. So cell-to-cell contact is lost. Last one is metastasis. You have spread to the different organs via lymphatics or the blood. Do I need to know the terminology? Yes. Do I need to know the definition? Yes. So put a star on this slide. Okay, here, this is a ductal carcinoma in situ. So this is a pre-invasive, right? You can see here the membrane, the basement membrane is still intact. So it's within the lobule itself, right? We're gonna learn more of this in next term or next module. So DCIS, right? Compare this one with this. It's invasive ductal carcinoma of the breast. You can see here that the basement membrane is not intact. It is now going to the fat cells, right? It's now spreading. What's the difference between benign and malignant? Put a star here. Benign, well differentiated. well demarcated, no metastasis. Malignant, poorly differentiated, rapid rate of cell division. In microscopy, I can have enlargement, polymorphism of the nucleus, and numerous mitotic figures. And I can have metastasis and relapses. Another table, you need to know the names. If it's benign or malignant, you can read that one. Again, same thing, you can read that. Your leisure. Most common type of cancer in men, prostate. In women, breast cancer. However, highest mortality rate in both is the lung cancer. Okay, that's high yield. Carcinogenesis is due to DNA damage, mutation, chromosomal translocation, or amplification. What are the genes involved? Oncogenes and tumor suppressor. Proto-oncogenes, you have a, what is this? Gain of function or loss of function mutation? For proto-oncogenes.
Gain of function.
Do we all agree that it's a gain of function mutation?
Yeah.
How about tumor suppressor gene?
Loss.
Loss of function. Okay, let's see. High yield tape, high yield slide, put a star here. This is your what happens to cancer. This is a good slide because you have some drugs involved here. Okay, so what is the highlight or characteristics of neoplasia? There's a lot of them. Tumor promoting inflammation, sustained proliferative signaling, evading growth suppressors, all of that one. Memorize it, please. It's all in here. And the drugs that are involved with each, okay? Oncogene is gain of function mutation, right? Only one allele needs to be damaged to form an oncogene. What's the difference between a proto-oncogene and an oncogene? Proto-oncogene is normal. It is normal in your cell division and cell differentiation. However, if one is damaged, it becomes an oncogene. Now, this is a high yield table. Put a star here. Do I need to know everything? Everything is high. Everything is high yield, I think. But I'm gonna highlight the most important ones. BCR-ABL. This is for your CML. Chronic myelogenous leukemia. 922. This is your Philadelphia chromosome from term 1. Don't forget. HER2/neu for breast cancer. Okay. RET, MEN2A and MEN2B, endocrine neoplasia, endocrine neoplasia, NMIC and CMIC. NMIC is neuroblastoma. CMIC is for Burkitt's lymphoma. Translocation 814, EBV. What else? BCL2, follicular lymphoma. Translocation 14. I think those are the high yield proto-oncogenes. Put a star here, know everything. I'm just gonna highlight the important ones. P53, right, the guardian of the cell. RB, retinoblastoma. BRCA1, BRCA2 for breast cancer. NF1, NF2 for neurofibromatosis. TSC1 and TSC2 for your tuberous sclerosis. VHL for von Hippel-Lindau, and your WT for your Wilms tumor. Another high yield point, put a star here. This is high yield. Know everything. Substance, occurrence, malignancy. Benzene, cigarette smoking. Okay, if you smoke cigarettes, benzene. Vinyl chloride, if you work pipes, PVC pipes, they have vinyl chloride. Angiosarcoma of the liver for vinyl chloride. Hepatocellular carcinoma for vinyl chloride. Nitrosamines, right? Those who likes to eat cured meat or bacon. Malignancy, gastric cancer. You have increased risk of gastric cancer. Aromatic amines. If you work in a rubber plantation, right? Rubber plantation, aromatic amines, beta naphthylamine. They're going to be sneaky. They're not going to say aromatic amines. They're going to say beta naphthylamine. think about transitional cell carcinoma or bladder cancer. Asbestos, right, for insulation, your work in construction and shipbuilding. Malignancy, lung cancer. Bronchocarcinoma is much more common than mesothelioma. Ethanol, if you're an alcoholic, malignancy involved HCC, you're damaging your liver, hepatocellular carcinoma, and squamous cell carcinoma of the esophagus. We're going to learn later about Mallory-Weiss syndrome, about Boerhaave syndrome. Alkylating agents, if you go in chemotherapy, right, you can have lymphoma or leukemia. Again, cigarette smoking, there's a lot, right? Soot and tar, look at the cancers here. Everything, cervix, mouth, esophagus, larynx, lung, pancreas, bladder, like everything. Radon in basement and uranium decay, lung cancer. Aflatoxin, stored nuts and grains, hepatocellular carcinoma. Arsenic, pesticides, herbicides. For lung cancer, squamous cell and hepatic angiosarcoma. So this is a high yield slide, okay? Non-ionizing, ionizing radiation, you can read that. Another high yield oncogenic infections, EBV, Burkitt's lymphoma. EBV, could you tell me the characteristic of EBV? Is it double-stranded, single-stranded? Is it the DNA? Is it envelope? Is it naked? Double-stranded DNA, that is envelope. This is your HHV4 or HSV4. Don't forget EBV, Burkitt's, Hodgkin's, oral hairy leukoplakia, nasopharyngeal carcinoma. We're gonna say a man from China, right, has something in his nose. So think nasopharyngeal carcinoma, EBV. HBV, hepatocellular carcinoma. HHV8, this is your Kaposi sarcoma. HPV, this is 6, this is 8, squamous cell carcinoma. High yield HTLV1, adult T-cell leukemia. HCV, hepatocellular carcinoma. Schistosoma for transitional carcinoma of the liver. Clonorchis sinensis, cholangiocarcinoma, and H. pylori for maltoma, and gastric adenocarcinoma. So this table, right, starting from here, please know them by heart. Know proto-oncogene. In the USMLE, there are some questions about chromosomes now. So I think it would be good for you now to know the chromosomes that are involved, okay? Know the gene product and the associated malignancies. Again, here also for your tumor suppressor genes, know the gene, the chromosome, the gene product, and some associated malignancy. Chemical, the substance, occurrence, and malignancy. So everything here is high yield. Please know them by heart. So what's the difference between grading and staging? So when we say grade, we are looking at the histological appearance, right? And in grading, it's from G1 to G4. Do I need to know specifics of each grade? No, just remember, if it's undifferentiated or anaplastic, it's high grade. If it's well differentiated, it's low grade. But grading is not the most sensitive for neoplasia. What is it? It's staging. Why? Because you have TNM. You have size, you have involvement of the nodes, you're looking for metastasis, right? You have a TNM staging. It classifies the tumor according to spread throughout the body. So this is much better for prognostic method rather than your grading, okay? So staging is important. Why? Because you have TNM. You can assess the size, you can assess the lymph node, you can assess for metastasis, okay? What's the most important here between the TNM, between the three? Which one is the most important for prognosis? Your N and M. Why? For metastasis, okay? So between grading and staging, which is much more important? Staging, because it classifies the tumor according to spread. Between the TNM, which is much more important in prognosis, N and M. Why? To detect the presence of metastasis. So this is just an example of carcinoma of in your peritoneum. You can see those specks things there. This is a peritoneal carcinomatosis. It metastasized, right, to the colon. So do you need to know the mechanism of metastasis? Just remember loss of EC adherent expression, right? You have overproduction of your collaginases and your metalloproteinases, everything. We talk about that. This is just some pictures of metastasis to the liver. Look at that. Metastasis to the lung. Metastasis to the brain, right? Another one for the liver. Now put a star here. If it metastasizes to the liver, most commonly the tumor is located in the colon, stomach, or pancreas. If it metastasizes to the bone, the tumor is located in prostate, breast, kidney, thyroid, lung. If it metastasizes to the brain, the primary tumor is located in your lung, breast, melanoma, colon, or your kidney. So this table is also high yield. Sometimes in cancer, you can have anorexia or cachexia. Why do you have cachexia? Meaning you have muscle wasting, you have loss of fat because of inflammatory cytokines, specifically IL-1, IL-6, interferon gamma, and TNF-alpha. So you have weight loss, poor appetite, you have decreased adipose tissue, you have muscle wasting. This is a poor prognostic factor. If you have cachexia, what's the treatment? You give corticosteroids, or you can give sticky icky or a 420. You can give cannabinoids, okay? Some therapy, anti-neoplastic therapy, you can have curative therapy, palliative therapy, neoadjuvant therapy, or adjuvant therapy. Do I need to know the difference? Yes. So curative, you need to cure the disease. You give a therapy to cure the disease. For palliative, you're just relieving the symptoms. Neoadjuvant, neo before elective surgery. Adjuvant is after, A or after surgery. So different kinds of modalities. You can read that. We're good so far?
Yes.
Yes? Okay, let's do wound healing. What's the difference between primary and secondary wound closure? So primary is minimal inflammation, no scar formation. Secondary, you have formation of granulation tissue, right? Primary wound closure, usually seen in the hospital. Clean incisions, right? Secondary, due to stab wound. Think about that one. Irregular edges, right? You have scar formation. So here, first, if I hurt myself, if someone stabs me, what happens? Transient vasoconstriction within the first 5 to 10 minutes, right? Due to the release of prostaglandins and thromboxane. After that, I have vasodilation. Why? I have an increase in histamine, prostaglandin, kinins, and leukotrienes. So now, guys, when you go next term in Pathophys, in the lab, you're just going to need images. So just one image, and then learn to explain the pathophysiology. So for now, we're just looking at the image. I'm just wanted to train you. But by looking at the image, what's happening? You need to explain the pathology and the physiology that's involved. Okay? So here we have wound healing. Vasoconstriction within 5 to 10 minutes. We have why? Because you have a ruptured cell membrane, you have platelet granular secretion, you have increase in prostaglandin and thromboxane, I have a stab wound, transient vasoconstriction. Afterwards, I have vasodilation. Why? Because macrophages were going to be there, lymphocytes were going to be there, neutrophils are going to be in there, which increases what? Histamines, prostaglandins, kinins. These are vasodilators, your leukotrienes, right? Then what happens next? Let's look at the image here. Still continued vasodilation, still continued increase of histamine, prostaglandin, kinins, and leukotrienes. Why? Because you have an increase in your immune cells. You have an increase in your neutrophils. You have an increase in your macrophages. You're also gonna, your macrophages is also involved in immune cell recruitment and fibroblasts. proliferation, right? Afterwards, what happens? Okay, let's see here. What happens? You have contraction. So look at this. Look at the image. The epithelial cell is now almost there, right? We have now deposition of the fibroblast. You have now angiogenesis in the wound itself, right? So you have formation of new blood vessels. So you have collagen type 3 depositing in there, right? And the wound is contracted via myofibroblast. Don't forget the fibroblast, it's repairing the wound. So it releases your VEGF and your TGF-beta, which drives your angiogenesis. Why? Because you need blood supply there, okay? Look at the epithelial cell. They are releasing collagens, they are repairing, they're almost done. We're almost done with repairing the wound. And voila, lastly, you have collagen is deposited from type 3 to type 1. Type 1 collagen is found where?
Bone.
Type 1 collagen is found where?
Bone?
So BTS, K-pop, bone, tendon, skin. Give me a pathology that's involved with type 1 collagen. Osteogenesis imperfecta. Signs and symptoms?
Blue sclera.
Okay. Why do they have a blue sclera? What is that vein that can you see?
Sorry, to the what?
What's the vein? Why do they have a blue sclera? Because the sclera is so thin, you can see the vein. What vein is that in the eye? Choroidal veins, high yield. Okay, the choroidal veins, you can see choroidal veins. How about type 2? This is in the eye also, right?
Blood.
Type 3?
Reticular fibers.
Reticular fibers. Give me a pathology that's involved here.
Ehlers-Danlos.
Ehlers-Danlos. What's the difference between type 3 and type 5 Ehlers-Danlos? Which is more deadly?
The vascular one.
Which one is that? Type 3 or type 5?
Type 3.
Excellent. Type 3 is vascular. Remember, reticulin, right? Type 5 is just hypermobility. And type 4, where can you find type 4?
Basement membrane.
Basement membrane. Excellent. Good job. So look at this image now. Wound healing. We have collagen type 1 is there. So it's complete, right? It's complete. You still have some fibroblasts there. Okay. Do I need to know this? The phases? Know the characteristics, right? Remember type 3 collagen first and then type 1 collagen. Know the characteristics. Okay. So first, platelet aggregation, vasoconstriction, then vasodilation. We'll talk about this. Then you have inflammatory cells coming in, neutrophils, macrophages, lymphocytes. Then you have granulation tissue formation, type 3 first, okay? And then type 1 afterwards. And then you have a scar formation. This is an example of a hypertrophic scar. This is due to excessive deposition of what type of collagen? This is due to excessive deposition of what type of collagen? Hypertrophic scar.
Type 1.
Careful. Hypertrophic scar is increase in type 3 collagen. Look at the organization of the fibers, of the collagen fibers. They are parallel, okay? And they are confined to a border, okay? They are confined to a border. So hypertrophic, increase in type 3. Tres, collagen, they are parallel. They're confined to borders. Contrast this one with this. Oh, this is a keloid scar. Increase in type 1 and 3 collagen for your keloid. Look at the organization of the collagen. They're disorganized. They extend beyond the borders of the original wound, and they recur frequently. Increased incidence in ethnic groups with darker skin for your keloids. Okay, so please know the difference between a hypertrophic scar, which is increased deposition of type 3 collagen, versus keloid, increased deposition of type 1 and 3 collagen, You have a disorganized formation of collagen. They extend beyond the borders of original wound. Okay, we're still good. I know it's 12. Do you need a break, or do you want me to move on?
Keep going.
Keep going. Okay, guys, the skin pathology, we didn't have that in our cohort. So I don't know if you did you discuss this one. I don't. So I just grabbed something from first aid and amboss. So did you discuss about this? The difference in the macule, papule, nodule, plaque?
Yes.
Okay, thank you. Okay, so this is one advantage of you guys. Okay, you discussed skin pathology. In our term, when I was in term 4, this is nada. Well, anyways, it's low yield on step 1, so don't worry about it. So differences, let's look at the picture, right? Let's look at the picture. Let's try to explain what's happening just by looking at the picture. So normal, you have stratum corneum, the topmost layer, epidermis and the dermis. Look at the macule. Macule, there's something going on with your stratum corneum and epidermis, right? It is less than 1 centimeters, okay? A papule is there's something growing between in your epidermis, right? So it's a raised in your papule. So it's a raised what do you call this one? It's not a nodule. So it is a raised border in your epidermis that is less than 1 centimeters. Okay. Contrast that one with your nodule. Your nodule is in your dermis. That's big. It's more than 1 cm. Your plaque is more than 1 centimeters, and it affects your dermis and your stratum corneum. Okay. When in terms of the vesicles, bulla, pustule, these are about fluids. There's fluid. Vesicles affects your epidermis, less than 1 centimeters. For bulla, it's more than 1 centimeters, but it can either be subcorneal, meaning below the stratum corneum, intraepidermal, meaning between your epidermis, and subepidermal, meaning below the epidermis. Pustule is just a collection of pus. Okay, so you need to know the terms. Okay, let's see. You need to know the terms, the primary lesions, and the description. Okay, where does it occur? So I like this one. This is a good image. Put a star here. But if you like tables, put a star here. And descriptions. Okay. Did you talk about this one, the secondary ones? Secondary skin lesions. Yes?
Yes.
Okay. So by just looking at the image, we can explain it. Erosion. Where is it? Stratum corneum and epidermis. Excoriation, you go in deep. You go in the width of your stratum corneum and your epidermis. An ulcer involves the dermis, the 3 layers, your stratum corneum, your epidermis, and your dermis. A fissure is a cut, straight cut. So your stratum corneum, epidermis, and your dermis. The necrosis, necrotic tissue, it involves the whole layer also. Okay? Scale, it's just on top, on your stratum corneum. A crust, it involves your epidermis and your stratum corneum. A scar is in the dermis. It's always in the dermis. Keloid is always in the dermis. We talk about the difference between hypertrophic scar and a keloid scar. Atrophy of the whole layer, right? Look at the layer of your dermis, it's smaller. Look at the layer of the epidermis, it's smaller, and the stratum corneum. Put a star here. Know the description of each. Did you talk about the difference between hematoma, petechia, ecchymosis, exanthem, enanthem, like that?
Yeah.
Yes? Okay,
Yes.
so put a star here then. Okay, so hematoma, there are different types. Non-palpable and palpable. Non-palpable, petechia and ecchymosis. It depends upon the size, okay? Petechia less than 3, Ecchymosis more than 5. A palpable purpura is a red-purple lesion. Rashes, exanthem, enanthem. Enanthem is confined to your mucous membranes. Erythemas is a reddening of the skin resulting in vasodilation. Maculopapular rash. These are non-palpable lesions, usually due to infection. Think syphilis, think Rosola infantum, think rubella, blueberry baby, right? Maculopapular rash. Lichenification is just thickening of the skin. For example, lichen planus, thickening of the skin. Eczema, it's a non-contagious dermatitis. You have pruritus, erythema, and some papules. So put a star here. Know the lesion, know the description. Dermatopathology, put a star here. What's the difference between each? The characteristic and example. Acantholysis, separation of your epidermal cells due to, think about deficiency in E-cadherin, your desmosomes, right? So think pemphigus vulgaris. What can we see in staining in pemphigus vulgaris? How are we going to describe pemphigus vulgaris?
Fishnet.
Fishnet, excellent. Acanthosis is hyperplasia of stratum spinosum. Acanthosis nigricans, okay? Don't forget that one. Commonly seen in what? Acanthosis nigricans is commonly seen in people with
diabetes or
exactly diabetes. It can also be seen in what in the woman 9 months in pregnancy, which is very, very common, commonly seen in pregnancy. Also in psoriasis. Hypergranulosis, thickening of the stratum granulosum, granulosis, granulosum, stratum granulosum, lichen planus. You can have lichen planus simplex, lichen planus chronicus. Hyperkeratosis, thickening of the corneum. Corneum sounds like. So commonly examples, psoriasis and callusis. Parakeratosis, you have a retention of the nuclei in the corneum. You have actinic keratosis. For spongiosis, sounds like edema, right? Spongiosis, like a sponge. You have intercellular edema, commonly seen in acute dermatitis. So put a star here. Okay, let's look at the specific diseases. Erythema nodosum. So for the following slides, please tell me if you discussed this or not. Okay, did you discuss about this? Erythema nodosum?
I think so.
yeah.
So this is idiopathic. So commonly seen in sarcoidosis, non-caseating granuloma, coccidioidomycosis. This is one of your systemic fungal infections. Histoplasmosis, systemic fungal. Strep, leprosy, and Crohn's disease. Remember, it's a painful lesion of subcutaneous fat, commonly seen where? Anterior shins. Lichen planus, the 5 P's. No, in first aid it says 5 P's. Here it's 6 P's. It's pruritic, purple, polygonal, planar papule, and plaques. Just know the 6 P's. So you can see Wickham striae. You have a reticular white lines. In the vignette, they're going to say sawtooth infiltrate of lymphocytes at dermal epidermal junction. It is associated with hepatitis C. How about this? Yes or no? You talk about pityriasis rosea. This is a herald patch, right? Christmas tree distribution. If you see Christmas tree distribution, think about pityriasis rosea. Psoriasis, high yield, unregulated proliferation of keratinocytes, aggravated by drugs. It's well demarcated flat, salmon-colored papules with silver scales. They love that. Salmon-colored plaques with silver scales, commonly in your flexors, right? Neutrophils, they collect in stratum corneum. If you try to get rid of the scales, you can have Monroe microabscesses. In the vignette, they're going to say pitting of nails. And you can have rashes in your flexor muscles. Seronegative. Why are they called seronegative? because there is no rheumatoid factor. You only have HLA-B27, high yield. So there are different kinds: psoriatic, ankylosing spondylitis. This is a bamboo spine. Think about this. Inflammatory bowel disease due to Crohn's and ulcerative colitis. Reactive arthritis. This is due to infection. Specifically, if you're young, if in the vignette it's a young male or female, and they have arthritis, right? Conjunctivitis, urethritis, think about sexual disease. It's most commonly in chlamydia and gonorrhea, right? Reactive arthritis. Sarcoidosis, non-caseating granuloma. In the vignette, they're gonna say increase in ACE and increase in calcium for your sarcoidosis. You can also have polymyalgia aromatica, which is it travels. For this one, you have pain and stiffness in the shoulders. It is most commonly seen in temporal arthritis. Fibromyalgia, widespread musculoskeletal pain associated with stiffness. Okay, most common in females. So how do we treat it? Regular exercise and sometimes antidepressants. But the high yield here is sarcoidosis. And I think I have, I remember a question about fibromyalgia on STEP. Fibromyalgia, widespread musculoskeletal pain associated with stiffness. So SLE, another high yield point. So malar, rash, joint pain, fever, and reproductive age, female and African descent. What kind of endocarditis is associated with SLE? Liebman-Sachs endocarditis. And lupus nephritis, type 3 hypersensitivity. What's the diagnosis? Do I need to know all of these antibodies? Yes, specifically anti-Smith. And if it's drug-induced, it's anti-histone antibodies, okay? So SLE, you have that malar rash or a butterfly rash. You have LSE for SLE, haha, Liebman-Sachs endocarditis for your systemic lupus erythematosus. You can have nephritis, right? Anti-double-stranded DNA antibodies, anti-Smith antibodies, anti-histone antibodies for drug-induced. How do we treat SLE? Steroids, just give them steroids, NSAIDs, immunosuppressants, and hydroxychloroquine. Antiphospholipid syndrome, this is the most common form of your SLE. Remember, it can have false positive VD-RL. Why? Because of anticardiolipin antibody. So if you test them for gonorrhea, for Neisseria gonorrhea, via VD-RL, it can have a false positive result because they can react to the cardiolipin in the test, okay? That's antiphospholipid syndrome. Did you talk about polymyositis and dermatomyositis?
No.
No, okay, let's skip that. How about this? Oh, myositis ossificans, don't forget. Metaplasia of skeletal muscle into bone following muscular trauma, okay? Look at this one here. You can have,
No.
how about this one? Yes or no?
No.
No. No.
No.
No.
Yes, yes.
So
Yes.
pemphigus vulgaris, what is the defect here? Desmosomes, your ECAD appearance, fishnet appearance. Okay. It can also involve the mouth, lesions in the mouth. You're going to learn next term about the different kinds of pemphigus vulgaris, type 1 and type 2. Bullous pemphigoid, you have the hemidesmosomes, bullous bellow, right? You can have, what can we see in the stain for bullous pemphigoid? You can see a thickened separation in the epidermal-dermal junction, okay? For melanoma, don't forget ABCDE of melanoma, asymmetry, right? Those kinds of things. You talk about lentigo maligna and acral lentiginous, yes or no? No?
No.
Okay, I think this is term 4. Basal cell carcinoma?
Yes.
Okay, basal cell, upper lip, lower lip? Commonly seen in? Upper lip. Think about BS. BS, B, upper, basal cell. S is squamous, lower. Okay, BS. All right. Most common skin cancer, sun-exposed areas. Look at the histology. Basal cell is palisading. They love that. Pseudo-palisading in the vignette. That's your basal cell carcinoma. How about squamous cell carcinoma? What can we see in squamous cell carcinoma? Oh, thank you, Fatima. Mnemonic. Happy birthday, Dr. Pepper. And my desmosomes, bullous from desmosomes. That's a good one. Okay, so how about in squamous cell carcinoma? What can we see?
Keratin pearl.
Keratin pearls. Good job. Albinism, tyrosinase, right? Don't forget that one. Associated with Shediac Higashi. There's something wrong with the list gene. Xeroderma pigmentosa, nucleotide excision repair, right? I think that's it. Let's take a break. Is 10 minutes okay? Or you need more time?
10 minutes is fine.
10 minutes is fine. Okay, see you then.